this is a games level CrossFit athlete. So somebody that went to the CrossFit Games. So they're fit. They train a lot. They've been doing this a long time. They're strong, et cetera, et cetera.
Right.
So back pain. I still did orthopedic, especially for low back pain. I do orthopedic testing because I want to know if it's disc, how bad is that disc, and in what movements are we going to trigger that disc. So I want to know if there's nerve root involvement, if there's radiation, where is it at. So if I know which nerve, I can say, okay, let me check the strength of that nerve distribution. This is a good time to do some orthopedic tests. I mean, are they on the verge to really rupturing this thing? I mean, they're just a sneeze away from cauda-equina syndrome. Well, I want to know that, and or any red or yellow, red flags. It hurts really bad at night, and none of the movement matters. Back's extreme pain. I had a guy not too long ago with kidney stones that, after like 2 visits, I'm like, I don't really think this is something for me because none of your tests make sense.
Right.
And then he messaged me a few days later, and he's like, "Oh, I had, that lithotropic whatever vibration, and the stones are gone, and my back pain's gone." So,
nice.
So with her, she had back pain, specifically on one side, left side, and it seemed discogenic. So I do my tests, but unlike some discs, which are only painful in flexion, she's painful in extension and flexion. And her neutral position is more extended. So she stands extended. She's, if anybody knows PRI, apical expansion is just completely limited on both sides. So she can't keep her ribs down. Basically, she can't keep her ribs down and breathe in. The ribs have to go up. So very extended. So basically in a state of compression on the posterior elements and disc a lot, and a little bit of a butt wink at the bottom, so that pelvis reverses at the bottom of the squat. All her pain is in deep movement. So at the bottom of the squat, the pull off the floor in a deadlift, cleans are worse because you hold more weight and it'll drive her deeper, versus maybe a snatch is not as heavy and she doesn't have to go so deep, so the back pain's not so bad. So in other words, now I'm trying to look at what I tell her is, why the left side? Like, why is your left side breaking and not your right? Because it can just be, well, that one just happened to break first. But I noticed a little bit of more hip restriction on that side. I noticed that the rib flaring or the rib extension on the left side was worse than on the right side. In other words, her ribs could go down a little bit better on the right than the left. It seemed based on a few tests that the left hip was also a little bit more forward than the right ilium. So in other words, she's just more in a state of extension on the left side than she is on the right side. And we can just call it lumbar.
Like a Thomas test.
Yeah.
Got it.
Exactly. Yeah. Stuff like that. And so if you can just think like the lumbar complex is extended, but it's a little bit more extended on the left than the right. So in my mind, and this is where we create a mental or a vision of what the problem is. And I could be completely wrong, by the way. But in my mind, she's kind of hyper compressed more on the left than the right. And then when she runs into that hip early, she has a stronger reversal of her pelvis into more of a butt wink at the bottom. So she goes from squeezing the donut on one side to, at the bottom of the squat, squeezing the donut on the other side. And this is that idea of moving through extension to neutrality to flexion and back under load. If you're just going to squat in Hong Kong and read a newspaper, you're fine. You can go through extension and flexion. But this is not a normal person. This is somebody who lifts heavy weights at high volumes and a lot of training. So this extension flexion cycle is almost like the research that's done in the lab, like on these porcine or these pig models where they take spines and just put them in a machine and just bend them until the disc blows out. That's where a lot of this research comes from. And that's kind of what she's doing, going from extension to flexion, under load. And so this was a good example where I could tell where the pain's coming from based on orthopedic testing, but the solution is based entirely on all the other tests. You can see it in the squat, right? You can ask questions of, when does it hurt? By knowing it hurts at the bottom of a squat, by the pull off the floor, I'm getting a picture of where the pain is coming from and why, right? So I know now the pain trigger, and I'm knowing, I know the pain location, I know the pain triggers, and I'm starting to see some dysfunctions side to side to maybe figure out why it's left versus right. So it's this holistic approach that helped me kind of narrow down. Now the outcome will verify it or not. And if it turns out she's doing everything I'm saying, but it's not really improving, well, then we got to see, are the tests that I use to base that off of improving, if they're improving and she's still in pain, well, now I'm like, okay, maybe I'm wrong. If they're not improving, she's still in pain, well, then maybe the solution I gave is not effective yet. So either have to keep doing it or we have to change it until we get those tests to change. So once that the hip moves well and she can breathe in while she keeps her ribs down and a few other tests, those become either they change for the better, and then she should be doing better, right? If my theory is correct. So that was a long-winded way of taking you through the whole thing from front to end, but I didn't want to go too deep. So
No, I think that was awesome, man. I loved hearing that, actually. So like, I want to just kind of cap this off probably with like a few strategies, just kind of take home kind of stuff and things that popped into my mind. Like I'm very much like you, outcome oriented, kind of the patient centered, outcome oriented. I don't really have a technique I'm pushing. I want you to get better, and this is specifically about you. So like, I'm thinking, her left to right stuff, you're trying to correct some left pelvic dysfunction in an overly flexed position where it is not able to support a spine, perhaps, as it goes to that flexion and extension phase through her lifts. But because that pelvis, and this is just my translation, because specifically that left hemipelvis does not support the spine through the flexion and extension phase, what would be the pelvis should be flexing and extending through a squat, through a clean, those things you enumerated. And because that left pelvis is not, she is getting an excess of load into her low back. And I agree also as well, we were talking about the ribs kind of above not being able to breathe in into that flex state. In other words, there should be a good amount of flexion and extension held through the ribs. Those ribs being up are telling me, when you're going through flexion extension, let's just keep it simple. If those ribs are up, more specifically on the left, that left side is in extension. The neutral level between the phase of flexion to extension, she's living in extension always, which is a great place to be in one part of a lift. It's a vital part of stuff, but if you're living on that end, you're never getting out of it and you're just jamming into it further. So rather than being able to flex and absorb some load and tension through the left rib cage, torso, you could say the intra-abdominal area holding pressure, that pressure is then absorbed furthermore into her spine, into that kind of segment that you're kind of talking about with pain. So the first two strategies is, in my mind, and I'm being very general, try to get her left rib cage, try to get her rib cage in general. I mentioned her right side too. Get her rib cage to absorb stress. Teach it to do that. Same thing with that left pelvis, because those are the two, some people would say energy leakage, right? They are not pulling their weight. And so that force is being jammed into her back at a high rep, at a high load, repetitively. So this goes back to what I was saying in the last episode. I'm going above and below very quickly to help support that low back. I'll be interested to see how that turns out. But in terms of strategies to fix it, that's what I'm thinking first and foremost.
Yeah. I mean, very similar. I would say I'm still have to worry about the other side because they're both,
of course.
She's extended in general. It's just maybe worse on the left side. So that's could be the reason why it's happening on that side. But my initial focus is to get her neutrality to be not in a state of hyperextension. So get her, her pendulum is not sitting in the middle at rest. It's swung to one side, like you were kind of hinting at. So that way, if we can get her more towards neutrality, well, then you can move into extension from neutral and you can move into flexion from neutral. You're not swinging, you're not always in extension, then you have to swing to flexion. And the real kicker is that you'll see the more extended the individual, the more they reverse completely into flexion at the bottom of the squat. And that's it seems counterintuitive because you're saying you get injured because of flexion at the bottom of the squat because you're so extended. But when you're extended, when the ribs are up in the front and the pelvis is forward, you now close down on your hip range of motion. So in a state of extension, your acetabulum covers the femur head more. So as you squat down, that femur, the neck of the femur, hits the acetabulum early because you're in a state of extension. And so therefore, that femur is now going to drive that pelvis, which was flexed, all the way around backwards into counter nutation, into a butt wink. So you've just smashed the disc and you have it under extension pressure, and then you roll it all the way around into flexion under load. And that can be a recipe for disaster. And I know there's like Greg Lehman, and some people say, well, you can do whatever and nothing really matters. I don't think he would say it's that simple, but that is a time, and I think Greg would probably agree, there's a time when that kind of volume of load on a sheer type of force, like a compressed disc that's going under constant change of extension to flexion and back, eventually wears away on the annulus or on the disc itself. So yeah, we need her to be able to start more from neutrality, because if she begins the squat more neutral, she has more hip range of motion, even without improving the hip. She automatically has greater clearance. So you'll see the butt wink go down as the neutrality from the beginning of the squat is there. And then after that, you can work on things like ankle mobility, make sure the knees are fine, and hip mobility. And then you even increase the likelihood of the further you can descend without the hip joint or the ankle joint coming to end range and then driving the pelvis back, right? So it at first, it's getting her into neutral, and then it's say, okay, let's get that left hip working better, and let's check your ankles to make sure they're not limiting it as well. And again, not orthopedic tests, not going to get you there. They're not going to get you to where I just spoke about. So it's that combination that'll, yeah.
No, it makes, I'm seeing it pretty clearly. I think what I'm hearing is that you have built a pretty big narrative around her complex kind of movement. And I think that Lehman would argue that you can't prove that's his voice. You can't prove these mechanics second to second. And I don't think you're saying, look, I'm doing an X-ray every 2 seconds, but you have created a narrative, a good idea about which direction to go in, essentially. And now you have some things. And I'm gone. I'm back. Where am I? Fuck.
You just got to start over with your,
okay.
I think it cut out right at where you were going to say, I think Greg Lehman.
I can do it better.
Okay. You're yellow now. Hold on.
We're going to finish. We're going to wrap this up real soon.
Good.
Cool. So I think what I hear you saying is that basically, in relation to Greg Lehman, the Greg Lehman comment, he opposes that you can specify the mechanical problems related to an injury, and you can confirm that and the relation to that. However, I just hear you building a narrative. You're not saying I'm taking x-rays of her in each specific angle and you're determining that those angles are inappropriate. It's just a good story and an idea that you have in your head that gives you an approach with it, essentially. That's what I hear. And Lehman's not wrong, and I understand his biomechanical mechanism, but they're different stories, what you're doing versus what he's kind of saying. And so I think the idea that you want to start her more neutral, give her a bigger buffer zone, essentially, let her use the muscles and capacity that she has. But from an orthopedic, or let's just say structural standpoint, get her body to a more zero level so that she can flex, extend, and twist in all those areas before she starts impinging and shearing on capsules and tissue and beating it up. For me, the last thing I would say is besides getting a good narrative around their mechanical, painful, provocative movement, would be back to Gray Cook. Honestly, I think people overlook this quote, but he says, the most common reason for an injury is a previous injury. And that said, we can work on the back and we can loosen up a QL or something like that. And the second thing we do is go, what's the next injury? Oh, you had a right knee, perhaps. That was a bummer. And so if I'm not getting progress on that low back via a thorough novel that you built around her back pain story, I'm immediately going to the next oldest problem. That's my secondary strategy. But honestly, it sounds like you've got a good picture of what's going on with her. If you were my doctor, I'd be excited because I feel like you know what you're talking about, man.
Well, some of it's experience, and then some of it I just get wrong. And then you try to ask yourself, why didn't this work out? And what am I missing? And sometimes it sucks because people fall off and you don't get the answers to the question. And then you just have to move on with another case and think about it again. But I would think if you're on that road and you're saying, okay, I don't think like that yet, how do I get there? I still, we already talked about that earlier, but I still think there's a good role for the people that say, okay, I can do my orthopedic tests. I can find out what's hurting. After that, I'm just going to find dysfunction. Just get good at that. Just get good at seeing it actively and passively so you can feel things. So, if you don't really, you can always do the passive care. So if something's hurting, you can always rub it and massage it and adjust it or mobilize it or whatever you need to do to help it. But then after that, like if you're just like, I don't know how to put that narrative together. Well, honestly, you may be better than the people creating a false narrative if you just say, if you think a little bit more like Spina and say, what works, what doesn't work well, and how do I make that stuff work better? So this ankle sucks. This hip also sucks. She can't rotate. I'm going to give her the things to work on those things. That's all. But that's what I can see. And I think that will go a long way. And then you can obviously apply the pain care, to take their pain down, or if they're dealing with pain, that's fine. But you'll go a lot further than arbitrarily throwing, just 12 exercises off of whatever rehab program your office has installed on the computer at them. The same ones, most likely. Do this monster walk, do this bridge, and that should take care of your back pain.
Bro, so, light bulb, and then we're going to wrap this up.
Yep.
I've thought this about the way that you've talked about your rehab before, and I've never said it to you, man. But I do think there is a perspective, and there's nothing different that changes about the process except for the perspective. The entire world is the exact same. You just see it a little bit different. I think, let's just go back to like an architect. I feel like you have an end game. You want things to look a certain way. You have an end model in your mind about how those ribs, how the spine, how the hips should all move in concert. And then you have a bridge that you are building to get there. So I'm building a deck in my backyard. At some point, there's just some holes and some dirt in my backyard. And I've got a couple posts. And the patient goes, man, my back's not better yet. And you go, hold on, we got to lay down some other stuff. I feel like the way that you describe your patient's pain, your process of injury, your ultimate goal, you have an end game. You have your dream house built in your mind. And now you're trying to figure out ways to actively get to that. And on the process of getting there, you're like, oof, we found out the ground is unlevel here. We may have to make a little bit of an adjustment. And I think that's one of the big things in terms of your treatment that I've actually stolen quite a bit. Having a pretty clear process of where I want to get this person to. And then along the way, the steps might change a little bit, but I've got a pretty good idea. I'll
take that. And sometimes, to be fair, creating the narrative can be easier than laying down those planks of wood. You know what I mean? Because you can know where you want to get them, And that, it sounds easy on paper, but that can be very difficult to get a hip to start to truly change, or to tissue to truly start to adapt to certain loads. It takes work, and it takes, that's where you have to get the patient to believe in you and maybe commit to longer term care sometimes, or trust your advice, or do your active care.
Right.
Man, building the deck can be harder than the vision of the deck. So that's a totally different skill. So I mean, I
think
feel
it's
like I
better
struggle
than
more with that.
I think it's better than just being like, let's build a deck, let's go for it. And you do need to do that sometimes before, we're going to figure some things out along the way. But I do think that if a lot of people could have a better picture of the end game in mind, that the process of getting there would seem a little bit more clear than before. That's what I would recommend. Really just listen to Bobby. Every once in a while, something comes up on my end, but really pay attention to what he says. Check out Dr. Spina's podcast. Definitely do that over Bobby for sure. And check out Gray Cook, but more so check out like our Instagram and like our YouTubes, and have a great week. Peace.
See you guys later.